Alright, on to Neisseria Meningitidis. Okay, these cocci tend to also form diplococci, kind of like our Neisseria gonorrhoeae. And they also have pili. Beautiful drawing right there. Where do we find this organism? Humans. So about 10 to 40% of us are carriers, be transiently part of our normal microbiota in our upper respiratory tract. So we're just kind of passing it around to each other. How does it spread? Well, it's droplet spread, so this has to be close contact, sneezing, coughing, the usual there, maybe some fomite transmission, so that would be indirect contact on some object like a keyboard or a drinking glass, for instance, so not airborne. And what does the disease look like? So meningococcal meningitis, this affects the lining of the brain and the spinal cord called the meninges. Okay, it's one of the few pathogens that's able to cross that blood-brain barrier. Other pathogens can cause bacterial meningitis. For instance, we talked about Streptococcus pneumoniae is one example. Then, of course, there's viral meningitis, which is usually less severe. And that's kind of counterintuitive because we think, oh, we don't have very good drugs to treat viral infections. But the viral meningitis, we don't get the toxin production. It's just way less severe. And so it's just not the same severity of disease. So the bacterial meningitis is the bad one. Okay, what kind of early symptoms do we see? Fever, sore throat, headache. Not just a little headache, but the worst headache you've ever had kind of headache. And then the stiff neck is the symptom that everybody kind of thinks of as being worrisome. These are the red flags that probably should either see your doctor or go to the ER right away. Okay, sometimes we see some nausea associated with it early on as well. And I say it's a good idea to see your doctor right away because this infection progresses really, really quickly. Sometimes just a matter of hours to life-threatening state here. Okay, so again, as infection progresses, so this again could just be a few hours, the endotoxin release really starts to ramp up with this organism. So all gram-negatives have endotoxin as part of their outer membrane of the cell wall. We've talked about that. That's the endotoxin. And usually that only gets released when the organism dies and the cell wall breaks up. Maybe just a little bit when the organism divides. Okay, but with Neisseria meningitidis, it releases parts of its outer membrane all the time. Okay, so we call that blebbing when it's, again, releasing endotoxin. Okay, and the endotoxin, I'll make a note here, is about 100 to 1,000 times more toxic than kind of typical endotoxin from, say, E. coli or something like this. Okay, so massive release of this endotoxin, again, by blebbing, and that causes some pretty serious symptoms here. We see things like petechiae, Petechii, or Petechii, I think is the way to pronounce that, sorry. So that's a word you should know. These are kind of little black spots on the skin caused by broken capillaries. And those start out as kind of a red rash, and then they start to turn purple and then black. They can come together to cause whole areas of the skin to get black and necrotic. Okay, so cell death. This hand here would probably have to be removed surgically. Okay. What else? Septic shock. Okay, that endotoxin, again, is causing massive inflammation. Okay, again, causes the blood pressure to go way down. We get an extremely high fever, neurological effects like delirium, even cardiac arrest, and all of this can lead to death in as few as like 6 hours. Okay, so once we start seeing these symptoms, even with treatment, maybe a 10 to 20% mortality. And about half of those survivors are going to be left with some kind of permanent disability, brain damage, blindness, deafness. Okay. So who is most at risk? Well, most patients are otherwise healthy, but again, some people are going to have an increased risk. Children, especially older than 6 months. If they're younger than 6 months, then they still have some protective antibodies, IgG antibodies that pass through the placenta from the mother, up till around 4 or 5 years. Okay, that age span is particularly at risk because this is a T-independent antigen. And we talked about young children don't have as good a response to that. Their B cells just aren't mature enough. Anybody that's living in close contact with lots of other people. So college students living in dorms, military living in barracks somewhere or jails, okay? People living in close contact. They found individuals with complement deficiencies are much more at risk. This is a pretty rare infection, and if somebody happens to get it twice, then they start looking and find, oh yeah, this person has a complement deficiency that's hindering their immune system. They're not as able to fight off this infection. Individuals that don't have spleens, maybe they had to be removed as a consequence of an accident, for instance. There's lots of macrophages in the spleen, and we think that macrophages are really important in fighting this infection. And of course, anybody that's immunosuppressed, has HIV, is on some immunosuppressive drug like prednisone, all of those are going to put someone at a greater risk. Okay, I'm not going to spend too much time on virulence factors because a lot of them are the same as Neisseria gonorrhoeae. They have the protease, again, that little different form of endotoxin, LOS. They also have pili. Okay, the difference is it's pili. The adhesions, the protein adhesions on the pili are going to be specific for the meninges instead of the urogenital tract. It does have a capsule, so remember that is unlike Neisseria gonorrhoeae, and that gives the organism some protection against complement. And phagocytosis, especially by the neutrophils, which are usually the first responders, remember. What does the capsule look like? Well, there's 5 main serogroups or varieties of capsule. And those are named A, B, C, Y, and W135. Somebody went a little rogue on naming that last serial group. Okay, so they're about 90% of Neisseria Meningitidis disease is caused by organisms with one of these 5 serotypes. Okay, so there's other ones, they're just not very common. Okay. So treatment and vaccine to finish up here. We typically will give either penicillin, or, which is kind of surprising that that's really used anymore, but that's according to the CDC, cephalosporins. Remember, those later generations of cephalosporin are able to cross that blood-brain barrier. Also, in conjunction with antibiotics, we're going to administer anti-inflammatories. Let me try that again. Okay, in order to counteract that endotoxin inflammation as a result of that endotoxin release. If you know that you've been exposed to someone that has the meningitis, then they give prophylactic. So before there's any symptoms, either rifampin, remember that targets RNA polymerase, or ciprofloxacin, same antibiotic they give if you're exposed to anthrax. That's fluoroquinoline, targets DNA gyrase. Okay, there are several different forms available of the vaccine. The most common one given is called MCV4. Okay, so that stands for meningococcal quadrivalent. Okay, so that covers those serotypes of the capsule, A, C, Y, and W135. That B serotype has been more difficult to get a vaccine that works against that. So that B serotype is not included. It's just not as antigenic. We've had, there is a vaccine now just to the B serotype, but you have to take that as a separate vaccine. Okay, so they typically would give that if there's an outbreak somewhere. And the most recent outbreak in the U.S. was in 2012 or 13. I'm forgetting exactly. 2013 at Princeton. There was 9 students sickened, and I don't think anybody died from that, but that was actually from the B serotype, which up until that time had not been common in this country. This is a subunit vaccine. So again, it takes the polysaccharide capsule, and we attach that to protein, just to give it a little improved antigenicity. Okay, it's a pretty good vaccine, 85 to 100% effective, so good protection, usually given to kids around the age of 11 or 12. Unfortunately, that's not an age where we always think about still giving our kids shots, but it's not effective if we give it to kids younger than that, and it requires a booster around the age of 16 to, again, give really good protection. Okay, that's all I got. Don't be afraid to email me any questions you have.